So right now in knee surgery, my goal is to, one, make the experience as short as possible for the patient and make the patient as comfortable as possible. So the modalities that we use, or the strategy that we use to help decrease the experience and decrease the amount of pain. Number one is the approach to the knee, to work outside the muscle just as much as possible. We know that the patients will have return of that muscle function quicker, so their rehab period should be decreased than if we violate the muscle. I think that makes sense to everybody. The other is just to accept that pain management is a very important aspect of recovery, and do all we can to decrease that pain. Unfortunately, pain medicines do have side effects, so our goal is to use numbing medicine as much as we can to decrease the side effects of narcotics. And so we have catheters that are placed, or little IV lines that are strategically placed using ultrasound in the front of the knee and in the back of the knee, to do all we can with numbing medicine to help alleviate the post-operative pain. And then in surgery, our goal is to be as accurate as possible, to restore the normal balance or ligament tension as the patient fully straightens the knee and bends it fully. It's not as easy as it sounds. Every knee is different, and it's important to understand what makes that knee different, why that knee failed. And we use a computer that's actually hooked up to the bone, so we know exactly where the bone is in space throughout the whole procedure. We learn about the knee joint in surgery in a lot, I guess, more quantitative terms than what I knew before surgery. Even though I've watched the patient walk, I've moved the knee, I still don't have the same understanding that I do once we have the computer in place and move the knee and stress the knee. During surgery, we're going to use the computer to also help determine the appropriate ligament tension. Ligaments are small rope-like structures that provide stability to the knee, and we're using the computer in certain tensiometers, so we're putting a certain amount of tension between the bones, and there's an optimal tension that the ligaments will work at, and we want to be in that range throughout the full movement arc of the knee. So those are the things that we can do to make that knee last. If the knee is in a good position, the ligaments are doing what they're supposed to do, the knee is lined up nice and straight, so we've restored the limb alignment, then that knee should last. The materials are durable enough that the patients can be very active and expect a long life or survivorship of that knee joint. So those are the things that we're working on. Other things that we're working on in the research area are just how pain interferes with knee surgery. That because the event of recovery is associated with pain, and some patients don't do well with pain, that can be a problem. So understanding who is going to have a problem with pain ahead of time, interacting with a pain management specialist, or interacting with performing certain modalities that may help control the pain in a more aggressive manner is another area that we're working on now. And then finally is understanding the aberrant inflammatory effect. That some patients, no matter what we do in surgery, and fortunately this is not a very high number, but scarring is an issue. And we believe that that's a result of a abnormal inflammatory response. So trying to pick that patient ahead of time, or trying to understand that patient early on in their course and then have treatment modalities effective for that is another aim of our research at this time.